Hello. First of all, I'd like to thank ausEE for inviting me to present my PhD research. And I'd like to thank my supervisors, which are in this slide. And when I'm talking about this research and temporary feeding tubes, I want to clarify that when I'm talking about temporary feeding tubes, I'm talking about nasogastric, nasojejunal, nasoduodenal, transpyloric tubes. So, I want to discuss some benefits and challenges of temporary feeding tubes. So, we know that temporary feeding tubes provide essential nutrition support for children who can't eat or drink enough to gain weight and grow. We know it can reduce their pressure to eat and to gain weight. For some children, having a temporary feeding tube can allow them to get their medications if they can't take it orally. And in some instances, if a child's in hospital, having a tube can help them be discharged home earlier from hospital. But we also know that having temporary feeding tubes can cause a child to vomit, can cause gagging, it can cause skin irritation from the tape. We know that tube insertions can be distressing and painful, distressing for the child, the parent, for clinicians putting in the tube. There can be a risk of tube dependency, whereby the child still remains dependent on the tube long after the reason for the tube has finished. And it can affect a child's quality of life, and it can be stressful, time consuming, and expensive. And these are some of the things that I looked at in my PhD research. So, moving on, a common story that we often see is a child has a temporary feeding tube in hospital for nutrition and growth, and the decision is made for them to be discharged home with that tube. And initially, things are going well in the hospital, parents are relieved and happy and hopeful. And then when they're discharged home, managing the tube can be very different to being in hospital. And that's some of the things that we wanted to look at more in my PhD research. So, what did we do? We followed children that had a temporary feeding tube all the way through. So we looked at them when they're first in hospital, when they had the tube inserted. We followed them when they went home, the midpoint when they're settled at home in the tube, and all the way until the tube was removed or 4 months' time had passed. And we chose 4 months' time because it's a temporary feeding tube. And previous research had told us that 90% of children have their tube out in the hospital that we did this research on at that point. So we followed them the whole way through. And we were really lucky that we had health consumers involved in this research. And health consumers were parents that had children with a feeding tube that we paid, that were involved in the design of this research. So we talked through what we were going to do, the type of research, the questions, the diaries, the concept, and they gave us some really good advice. And what we did was we did parent interviews at the start, the middle, and the end. And we asked questions to parents about what they thought about tube feeding all the way through and how they were managing. We encourage parents to keep diaries. And again, these were short 5-10 minutes questions that they could do on their phone. And they asked questions like, how are you managing this week? How's tube feeding going? How long is it taking you? And ideally, we wanted parents to complete those diary questions every week for the duration of time that their child had the tube. We did quality of life assessments on the children using a validated tool. And we did this at the start, in the middle, and at the end. And we also did a burden questionnaire. And we did that at the very end of the study or when the child's tube was removed or 4 months. And this burden questionnaire covered all the questions we could think of about the difficulties of tube feeding, like how much did it cost? How much time did you spend? Did it affect your family life, your work, your finances, the costs, everything? And what did we find? So the children that we had involved, we had 37 children, 36 had a nasogastric tube, it's the most common one. We had a range of children's ages, but the most common was about toddler age. And the most common reason for having a tube was growth and nutrition. The most common medical teams involved for the child's tube was cardiology, oncology, general pediatrics, and respiratory. And some of 5 of the children had the tube in before the study started, and 43% of those children still had the tube at the end of that 4 months' time. Looking at the parents, we had mostly mothers. We had about a half-half mix of parents that were working, that weren't working. About 44% had university education. 29% lived in regional rural areas. We had a mix of single parent and families that had siblings at home. And we had diverse backgrounds. We had 4 families that identified as First Nations, and we had 6 that identified as culturally and linguistically diverse. And just to give you a feel for where families lived, and this is the state of Queensland, 29% of our families lived all across that state. So this is where the main children's hospital is in Brisbane, and they lived all across regional, rural Queensland. And this is important to consider thinking about how far they were from the main children's hospital in this study. So the question that we wanted to find out and what families told us was what life was like living with a temporary feeding tube. And the first thing was that many parents said that they didn't feel prepared. Some said that they did, but many said that they found it was stressful. This is a quote from a parent saying, "When you're there on the ward and you're seeing so many people, it's all a blur. You're so tired, especially on the final day, as everyone is giving you information when you're leaving. When you get home, it's very difficult to recall those processes." And that parent is talking about the education that they got about their child's feeding tube as they were being discharged home. Planning and organization was very difficult for many families. And this is a picture of a very organized parent who had all of the feeds and equipment and consumables that they needed. But Queensland, as we know, can get very hot. And all of those feeds weren't in a fridge and they all curdled and the parent had to throw them all out, which is very disappointing. And safety was really important for families. Parents wanted to be confident using their child's feeding tube at home and they wanted to do it safely. And this is a parent that gave us a quote and sent a picture about the pH strips. And the quote says, "The side of the pH strip label says we don't feed if it's a 5 or a 6 and we weren't sure. We never got a 4. It's a bit of a weird thing, hoping that I'm not drowning her." And what that parent is saying is that every time that you have to do a tube feed, you draw up an aspirate from the tube and you put it onto the pH strip. And if the number is 4 or lower, you know it's in the stomach because it's acidic. And if it's higher, like a 5 or a 6, there's a risk that it's in the lungs. So that's what that parent is worried about, that she's drowning her child. And this would be something that they'd have to do a pH strip aspirate every feed, every day, every week for as long as their child would need tube feeding. Another aspect was managing through trial and error and having to figure things out themselves. Many parents didn't know who to contact. There's a parent that said they couldn't get an answer about if their child could go swimming with a feeding tube from anyone in the hospital or the clinicians, and they got the answer from a Facebook group in the end. A lot of parents talked about managing with the equipment that they had, the equipment that they needed, the extra equipment that they had to buy. And this is a parent taking a photo of syringes that are single use, but they've been reusing them and the numbers are washing off, which is a risk if you're leveling out medication. And it says that perhaps they're not getting what they need. And becoming self-taught experts, this is a parent that was using lights instead of a feeding pump at home because they didn't get the pole. And this is another parent that has organized a system with hangers to make sure that the tube is running without kinking, so the tube feed is working and the alarm isn't going off all of the time, and figuring that out themselves. More challenges of life at home is sleep disruptions. Lots of parents talked about having to stay awake at night. This one parent said, I have to be up with him all night because he death rolls and I have to unravel the tube from around his neck." And you can see that photo of the tube wrapped around the child's neck. And the tape irritating the child's skin. You can see the rash that's been caused on the cheek from the tape that would have kept the tube on. And this is another parent showing the organization of having to do tube insertions. And for some parents that learned to put in their child's feeding tube at home happen very often. And the tube had an impact on a family's quality of life and family life at home. And this is a picture of, I suppose, the space needed. This is all of the paraphernalia that they needed on their kitchen bench for tube feeding, which takes up a lot of space. And going out was difficult. This is a parent whose organised a feed on the back of the car seat and organize that. But the parent also told me that every time they rounded a corner, they were afraid that it would tip over and leak or spill everywhere. And then tube feeding often affected going back to school or daycare or their siblings or everyone else at home being able to go out, go places or go on holiday. And the quote says, "There's a lot of frustration towards the tube from all family members this week." And remembering the diary that we ask parents to fill in every week, one of the questions was asking them how many hours a day does tube feeding tasks take for their child? And here's the answer. Giving a bolus feed took over 3 hours a day for parents. Getting all of the tube feeds ready, like making the feeds, organizing the syringes, turning on the feeding pump, getting the backpack ready, took over 2 hours a day. This is about replacing the child's tape, took over an hour a day. And for those parents, replacing their child's feeding tube at home took over an hour a day. And this is for the duration of time that parents had their child's feeding tube. So this is multiple answers that we got to get this data. The impact on parents' work. 61% of parents reported that they had changes to their jobs because of their child's feeding tube, and 38% of primary caregivers in this group, which were mainly the mothers, stopped working entirely. And looking at the loss of income for those primary caregivers, they lost $580 a month on income from not working. Their partners lost $700 a month. And something that we don't often think about or ask the question about is friends and relatives. Their impact on working, looking after the child in the feeding tube was not over $900 a month. And the cost of tube feeding, this is another question that we asked at the burden questionnaire at the end. So the direct medical costs were things like the tube equipment, the syringes, the delivery, the feeds, cost of clinicians, like going to a GP about the tube or having a private clinician managing your child's feeding tube cost just under $900 a month. And then the non-medical cost was everything else related to the feeding tube, like having to hiring help, like cleaners, babysitters to help manage with your child in the feeding tube, doing extra washing because of the tube, buying extra clothes because of the feeding tube, having to use your mobile phone use to communicate with a hospital because of the child's feeding tube, or buying extra food for hospital visits cost over $2,200 per month. And this is a parent that quote saying, "We wish we had been prepared for what was involved, the cost." And thinking about a child's quality of life, remember we said that we used a validated scale to check, and this scale went from 0 to 100, and the higher the score meant the better the quality of life. And I just want to highlight that this is a healthy child. That's the score done. It's about an 83. I want to show you what the score looked like for children with medical conditions. So children with stroke, cancer, HIV, type 1 diabetes, or inflammatory bowel disease. And the results from our study found that quality of life scores for children at the start, at the midpoint, and at the end were all lower than children with healthy children, but also lower the children with medical conditions, which is a really significant finding. And thinking about more results, again, children's quality of life, and thinking about the healthy children results, children with medical conditions, the higher the score indicates the better quality of life. And looking at children that lived metropolitan, so like close to Brisbane, near the Children's Hospital, but children that lived in regional, rural, remembering that map, further out had a lower quality of life. Children that were born preterm had a higher quality of life, but children that were toddlers had a lower quality of life. And again, those results all lower than children with medical conditions. And so I suppose for me as a pediatric dietitian, what surprised me from this research was the burden and the cost burden on families from this study. And in the burden questionnaire at the end, 60% of parents used cost coping strategies regardless of the income, high or low, that they had. And some of those cost coping strategies that we asked them was, did you have to use your savings? Did you have to reduce your leisure spending, like eating out at restaurants? Did you have to cut down on basic needs like buying food? Did you have to borrow money, sell possessions, work more hours, ask for cheaper prescriptions, or spread out your clinician appointments to manage the cost of tube feeding? 34% of families used 1 to 3 of these strategies in the list, and 26% of families used between 4 and 8 of those strategies, which was very surprising to me. Another thing was the reality overall of parents and what they told us throughout the whole period of time of the child having a feeding tube through the diaries and the interviews. And it was really obvious that many families struggled with the equipment that they needed, that they wanted, that they got, that they struggled to use. And one parent said, "I don't know if I'm able to get more pH strips, and I don't know how many we're entitled to. And do parents need to go and buy it themselves?" So this parent doesn't know how the pH tubes are organized, if it's going to be enough for their child and their feeds, and how to even get more and how to buy more. And then another parent, which is very common, parents said that the tape has been the hardest thing to manage. And before this research, I wouldn't have anticipated that that would have been an answer that parents would have said. Another thing was the medical caregiving that parents were doing for their child at home with tube feeding. And this was something that parents talked about a lot. And one quote said, "It's just hard from a mum point of view, having your child screaming because you're going to do something for their health." So this is a child talking about their child getting really upset when the parent is doing the tube reinsertion themselves at home, which is very difficult for many parents. And then the last one was the parents' concerns. So parents worried that their child wasn't feeding and needed a feeding tube. One parent said if they don't learn to feed, what else will they not do? What else will they not learn to do? If they don't feed, will they not talk? Will they not walk? And this is something parents talked about a lot. And also, an interesting point of this study, parents were very mindful of their situation and where they lived. And one parent talked about, several parents talked about, "I've often wondered, people in rural areas, remembering that map, how do they get by? Because I've had so many trips to the hospital," and thinking about the considerations about other parents and where they live and how easier or harder it would be living further away from the main children's hospital in Brisbane. So the conclusion that I want to stress is that we know temporary feeding tubes are essential and help children grow and gain weight if they're not able to manage orally. As a pediatric dietitian, the answer to this research is not no tubes. It's just considering that temporary may not be easy, has not been easy based on these results. And in this study, temporary was not temporary either, considering that 43% of those children still had the tube in at that 4 month time period. And tube feeding can cause significant burdens for families, thinking about the interconnection burden of financial, the lower quality of life of children, the family burden, and the time burden, all happening at the same time for families and children. And thinking about if you had a child that also was a toddler, that also was living rural or regional, how much harder it was, or if a family was struggling financially, how much harder it would be. And I want to use the analogy of an iceberg because when we see a child with a temporary feeding tube, often we focus on the growth and nutrition and how it's doing what it's supposed to do. But there's a lot of things that are happening under the surface that perhaps we're not talking about, and we're not talking about it. Families aren't able to tell us as clinicians, and change can't happen. And so I want to continue using that analogy and thinking about the things that are important for it to change. And I want to think about building understanding means that we have to be raising awareness. So Feeding Tube Awareness Week is important, thinking about advocacy for those families, and then education is important for families and clinicians and health services. But we can't build understanding by itself. It needs to happen with outcomes to make change. So doing research to prove that there is differences for these families and getting the data. We need redesign of health services and hospitals and community. And we also need policy reform to make those bigger changes. And they can't be separate. We can't do one without the other. And understanding is important, and outcomes, they have to happen overall. I put together some questions for parents based on the research that we did and some things that perhaps they'd like to think about if they had a child with a temporary feeding tube. And I'll start with thinking about or asking, could your tube education be filmed in hospital? Could you take photos? Could you include other family members so it's not just all reliant on one parent? Could childcare or school be involved and trained? Asking yourself as a family and parents, do you think that you can do this tube feeding plan at home? Is it realistic what they're doing in the hospital? Do you think you'll be able to manage that at home? Do you understand how to use all of your equipment, all of the syringes, the tube, the tape, the feeding pump? Do you have enough of what you need? Thinking about, do you need a letter for school, for daycare, for your work? Are you going on holidays? Do you need a luggage allowance letter if you want to travel? Thinking about, do you have a plan? This is a temporary feeding tube, so it should be temporary. Do you have a plan for a tube wean, tube removal? Is there a plan for when that's going to be talked about? Do you have an idea of how long that tube duration is going to be? Do you know where to get access for resources, written information, peer support groups? Have you been given good websites or information for when you go home? Do you know who your tube fitting team is? Do you know what the dietitian does? Do you know the role of the nurse? Who are the medical team that are looking after you? Who are they? What is their role? What are their names? And what are their contact details? Have you had a conversation about the cost? Do you have an idea of how much it's going to cost per month? And if that's a concern, is there some financial help, support available to you? Do you know what happens if you go wrong? If something goes wrong at home, do you know who to contact? And bigger questions are like, do you think this feeding plan is going to affect your family life? Do you think it's going to affect your job, your sleep, your siblings, your overall family life at home? There is some further information. So the research that I talked about is from my PhD research papers. These three here are all open access and free to read. There's lots of really good resources on the internet. Child Feeding is an Australian organisation website. Feeding Tube Awareness this week. There's Feeding Matters, which is a US organisation, and kidshealth.org.nz is a New Zealand organisation, and plenty more. But I have talked for as much as I can in the time that I have, and I'd like to thank you for all listening.